That exact terrifying moment when you realize the training wheels are absolutely officially off.
Oh, yeah, you know that feeling.
Right. I mean, you know the visceral feeling I'm talking about. You've passed the NCLEX, your license is active, you have that shiny new badge clipped to your scrubs, and you're standing at the bedside.
And everything is going wrong all at once.
Exactly. Your patient is highly complex. The IV pump is just blaring some occlusion alarm. A family member is staring at you, demanding an update on a lab result you barely even understand.
It's a lot.
And the monitor is showing a creeping heart rate. And suddenly, it just hits you with the physical force of a freight train. You are the nurse in charge.
Yeah, there is no instructor standing behind you to catch a mistake anymore.
It is a feeling of pure, unadulterated overwhelm.
It's the heaviest realization in the world, really. It's that precise moment when the academic theory you learned in a classroom, just collides with the chaotic reality of the hospital floor. The weight of another human being's life is sitting squarely on your shoulders. And I don't care if you graduated at the top of your class with a 4.0 GPA, that specific moment is daunting for every single person who has ever put on a pair of scrubs.
Absolutely.
The transition from student to independent practitioner is, it's arguably the most vulnerable period in a nurse's entire career.
Well, welcome to an episode of the Super Nurse Podcast. I am incredibly excited for our conversation today because we are tackling that exact vulnerability head on.
Yes, we are.
But before we jump into the clinical realities, we have to introduce the foundational brain behind this show, the incredible Brooke Wallace.
Right. For those of you who might be new to the community, Brooke has a truly impressive pedigree.
We are talking about a 20-year ICU nurse, an organ transplant coordinator, a clinical instructor, a published author, and someone who has just dedicated her life to mastering the bedside and mentoring others.
She's amazing. But, it is a crucial distinction to make right off the bat. My co-host and I are not Brooke Wallace.
We are absolutely not Brooke, though we are, honored to be channeling her expertise today.
We're here to deliver an episode built entirely from Brooke's extensive bedside knowledge, her personal clinical notes, and her signature ICU teaching style.
Right. The entire goal of this conversation is to help you, whether you're a nursing student nearing graduation or a new nurse navigating your first year, to translate that dense, heavy textbook knowledge into real-world, life-saving patient care.
Because we want to help you bridge that gap between passing a multiple choice exam and actually, catching a patient who is quietly crashing right in front of you.
And to help you on that journey, we invite you to join our community fully. Make sure you subscribe to the Super Nurse Podcast.
And if you're a visual learner, which, let's be honest, so many of us in healthcare are, you really have to go watch the highly visual comic book-based video version of this exact episode on YouTube.
Yeah, you can find it at our channel, Super Nurse Comics, and the link is right down there in the description.
Also, be sure to visit supernurse.ai for incredible resources, study guides, and clinical tools to help you along your journey.
Okay, so let's get into today's topic, which is really the ultimate bridge between nursing school and independent bedside practice. We're unpacking the reality of nurse residency programs, or NRPs.
This is such a huge topic.
It is. We're going to break down what they actually are, the gold standard benchmarks you need to be looking for when you're applying for your first job, and how to spot a fake residency, because those exist.
Oh, they definitely do. It's a predatory marketing trick.
Exactly. And we'll cover exactly how these programs shape your critical thinking and clinical judgment at the bedside.
Because deciding where you spend your first year of practice is... it's arguably one of the most consequential decisions you will ever make in your career.
It sets the tone for everything, right?
It really does. It sets the trajectory for your clinical habits, your professional boundaries, and honestly, your mental health.
So true.
To understand why a formal residency program is so vital, we first have to talk about the massive gap between nursing school and real-world bedside care. There is this very real, well-documented psychological and clinical phenomenon known as reality shock.
Reality shock. I mean, that is just the perfect term for it. I want to dive into this because I think nursing school inadvertently gives you a false sense of security.
100%.
You conquer the NCLEX, which is a beast of an exam, and you naturally think, okay, I am a nurse now. I know what I'm doing.
Right. You think you're ready for anything.
But we have to be honest about what the NCLEX actually tests. Passing that exam simply proves that you have the minimum baseline competency to not harm the public on day one.
That's all it is. Minimum competency.
Yeah, it proves you can memorize foundational concepts, recognize normal lab values, and, select the safest multiple choice answer in a controlled, sterile testing environment.
It absolutely does not mean you have the experiential pattern recognition of an expert nurse.
No, not at all.
What we know from practice and evidence is that new graduates undergo a massive, multi-stage transition phase. In the literature, you'll sometimes hear it called the becoming phase.
The becoming phase. I like that.
Yeah, it relies heavily on the novice to expert theory. You are moving from a novice, someone who relies entirely on rigid rules, lists, and step-by-step instructions, to someone who can actually read a dynamic, unpredictable clinical situation.
Let's translate that novice to expert theory into a real bedside scenario, because the difference in how the brain processes information is just fascinating to me.
It really is.
A novice nurse walks into a patient's room and sees isolated data points. They look at the monitor and see a heart rate of 110. They look at the blood pressure cuff and see 90/60.
Right, just numbers on a screen.
Exactly. They check the thermometer and see a temp of 99.1. And because they are a novice, their brain processes these as separate individual tasks to document.
They might think, well, the heart rate's a little high, maybe they're just anxious or in pain.
Right. And they think the blood pressure's on the lower side, but hey, it's technically within the acceptable parameter my instructor gave me. They don't see the danger.
But the expert nurse, on the other hand, doesn't just see numbers. They see a physiological narrative.
The story.
Yes. An experienced nurse walks into that same room, looks at the patient's mottled or flushed skin color, notices their slightly rapid breathing pattern, and instantly connects all those same data points you just mentioned.
Because they recognize the compensatory mechanisms.
Exactly. They know that the heart rate is climbing to 110 because the systemic vascular resistance is dropping, and the heart is pumping faster to try and maintain cardiac outbursts before the blood pressure completely bottoms out.
So the expert synthesizes the data and says, this patient is entering the early stages of septic shock.
Right. We need to draw a lactate level, hang fluids, and call the provider right now. The novice sees a list of numbers, but the expert sees the trajectory of a crashing patient.
I always like to compare nursing school to learning how to read sheet music in your quiet, comfortable bedroom. You're sitting there, you're learning what a quarter note is, what a treble clef is.
It's all very organized.
Very organized. You're memorizing the theory of music, and it makes perfect logical sense on paper. But your first year at the bedside,
oh boy,
that is like being suddenly shoved onto a brightly lit stage in the middle of a live jazz band where everyone is just improvising. The drummer is speeding up the tempo, the bassist just changed keys, and a massive audience is staring at you waiting for your solo.
That is terrifying.
It is. You know the notes, but keeping up with the tempo and the unpredictability of the improvisation is absolutely terrifying.
That jazz analogy perfectly captures the cognitive overload of the first year. Because at the bedside, the patient hasn't read the textbook.
Right. They never present with the exact classic 3 symptoms you memorize for a test.
Never. They have 3 different comorbidities. They have complex and challenging social situations. Their family is highly anxious and asking you questions while you're trying to think.
And they are on a cocktail of medications interacting in ways the textbook didn't even cover.
Exactly. The evidence tells us that unsupported new nurses face incredibly high stress, terribly low confidence, and very real skill deficiencies. They are trying to play the jazz, but they are so terrified of hitting the wrong note that they just freeze.
Which brings us to the fundamental purpose of nurse residency programs. They exist specifically to mitigate that reality shock and provide a structured environment for you to learn how to improvise safely.
Safely being the key word.
Right. And I want to be very clear here. A true residency program is not just an extended hospital orientation.
No, definitely not.
It is not a polite hospital educator showing you where the clean utility room is, or how to scan your badge at the Pyxis machine, or where the cafeteria is. Those are logistical onboarding tasks.
A residency is about professional role socialization.
Which sounds like a dense academic buzzword.
It does. But let's break down what it actually means at the bedside. It means teaching you how to step into the identity, the autonomy, and the legal responsibility of a professional nurse.
Right.
It's about building a robust safety net around you while your brain physically builds that clinical pattern recognition we talked about. Let's look at the bedside application of this. Let's say you have a highly stressed, overwhelmed new nurse on a chaotic med-surg unit.
A very common scenario.
Very common. They have 6 patients. Their brain is entirely focused on surviving a checklist. I have to pass these 9.0 a.m. meds. I have to finish my morning assessments so I don't get behind on charting.
I have to empty this Foley catheter. I have to discharge the patient in room 12.
Exactly. Because their cognitive bandwidth is completely maxed out by anxiety and task completion, they develop tunnel vision.
And that tunnel vision is incredibly dangerous because it means you miss the subtle physiological clues.
You miss the sepsis.
Yes. Going back to our sepsis example, if you are just trying to survive the shift and check boxes, you might document a respiratory rate of 24 and a heart rate of 105 and just keep moving to the next room.
Because you're so rushed.
You simply don't have the cognitive space to step back, and ask yourself, wait a minute, why is the respiratory rate 24?
Right. Are they in pain? Or is their body trying to blow off CO2 because they are becoming acidotic at the cellular level?
But a supported nurse, a nurse who is actively participating in a gold standard residency program, is being taught in real time how to think and who to ask.
They have a dedicated preceptor or a clinical coach right there beside them. And that coach isn't just taking over the tasks.
No, they're asking guiding Socratic questions.
Exactly. The coach says, what do you think about that heart rate? Let's pull up their white blood cell count from this morning's labs. Let's look at their urine output over the last 4 hours. How do these pieces fit together?
That real-time, side-by-side critical thinking support dramatically improves nursing-sensitive patient outcomes.
It intercepts errors before they ever reach the patient.
It essentially forces you to transition from being a passive task doer to an active critical thinker. So if the ultimate goal is to safely bridge that terrifying gap from a novice to a competent caregiver without causing patient harm or burning out the nurse, how exactly is a high-quality program built?
That's the million-dollar question.
Because hospital marketing departments are incredibly savvy. They will slap the word residency onto anything.
Oh, they love the word residency.
Right. We need to look at the anatomy of a true gold standard program so you know exactly what to demand from a potential employer.
Well, the first, and arguably the most rigid benchmark of a true gold standard residency, is the timeline. The clinical evidence shows us very clearly that the best residency programs are a minimum of 12 months long.
12 months?
Yep. Many of the most robust, highly accredited ones stretch to 15 or even 18 months.
Okay, I want to push back on that timeline a bit because I know a lot of eager nursing students who hear 12 months and just groan.
Well, I've heard the groans.
Like, why do we need a whole year? Let's say you have a brilliant new grad, someone who was president of their nursing cohort. They crushed the NCLEX in 85 questions and previously worked as an EMT.
A high achiever.
Right. Shouldn't they be able to figure out the workflow of a standard telemetry unit in, say, 3 months? Why force them into an entire year of mandatory classes and check-ins?
It is a very common question. And frankly, hospital administrators push back on it too, because, funding a 12-month program is a massive financial investment for a healthcare system.
Sure, it costs money.
But psychological data and clinical experience show us exactly why a full year is absolutely non-negotiable. A gold standard program is deliberately split into 2 distinct phases.
Okay, break that down for us.
So phase 1 is usually the first 8 to 12 weeks, sometimes up to 16 weeks, depending on the specialty. That is your standard heavy-duty clinical orientation.
Where you're side by side with a preceptor for every single minute of your shift.
Exactly. The primary focus there is rapid skill acquisition. Getting proficient at starting IVs, understanding the complexities of the electronic health record, learning the physical layout of the unit, and mastering the specific medical equipment.
That is what I call the honeymoon phase. You are sheltered. You are protected. You have a shadow who is ultimately responsible for the patients, so the true weight of the license hasn't fully landed on you yet.
That's a great way to put it.
Yeah.
But then phase 2 begins. This encompasses the remaining 9 to 10 months of your first year.
And this is where it gets real.
Oh yeah. During phase 2, you are off orientation. You are taking your own full patient assignment. You're technically on your own, but you are receiving structured, ongoing educational and psychosocial support.
So you're attending monthly intensive seminars, presenting case studies to your cohort, and meeting regularly with clinical mentors.
Yes. And the reason the support must extend to the 12-month mark is because of a very specific, well-documented psychological phenomenon that occurs right at 6 months.
The infamous 6-month dip. I really want to unpack the mechanics of this because nobody warns you about it in nursing school.
Nobody warns you, and then it hits you like a truck. At the 6-month mark, the honeymoon phase is completely over. The initial adrenaline rush of being a real nurse has faded.
And the heavy, grinding reality of the responsibility just sets in.
You realize, oh my gosh, I have to do this for 12 hours a day, 3 days a week, dealing with literal life and death for the rest of my career.
It's a heavy thought.
It is. And this is precisely when a new nurse's confidence plummets to its absolute lowest point. They often experience severe, acute imposter syndrome.
I remember that feeling. You might make a minor medication error. Maybe you give a routine antibiotic an hour late, and your brain just catastrophizes it.
Right, you spiral into thinking you are dangerous, incompetent, and wholly unsuited for the profession. If a residency program ended at 3 months, that nurse would be left entirely alone on the floor during their most vulnerable, fragile psychological period.
That's a terrifying thought.
The 12-month timeline is strategically designed to catch nurses right when they hit that 6-month wall, mitigating the reality shock so they don't abandon the profession entirely.
That structural safety net makes so much sense. It is not just about refining your clinical skills. It is about building the emotional and psychological stamina required to survive in modern healthcare.
You desperately need that cohort of other new grads.
You do. You need to be able to sit in a seminar room at month 7, look at your peers, and say, are you guys feeling like you are totally drowning and faking it every single shift too?
And when they all nod and say, yes, absolutely, it normalizes the struggle. It removes the shame.
That peer validation is a cornerstone of retention. And during that year-long safety net, the educational curriculum isn't just, random lectures on hospital policy.
No, it's structured around highly specific domains of competence. The Commission on Collegiate Nursing Education, known as the CCNE, outlines 5 core domains that a credible residency must cover in depth.
It is vital to translate these from lofty academic phrasing into plain English that actually makes sense at the bedside. Let's walk through those domains.
Let's do it.
Domain number 1 is person-centered care. Now, in nursing school, we hear patient-centered care repeated so often it almost loses its meaning. We think it just means being nice.
Right, getting them a warm blanket.
Yeah. But at the bedside, true person-centered care means recognizing that you are not just treating the diabetic foot ulcer in room 4.
It is about radically understanding patient values, intricate family dynamics, and the heavy influence of social determinants of health. It is the critical shift between a novice saying, well, the patient is non-compliant with their insulin regimen, and an expert asking, why isn't the patient taking their insulin?
That's the real question. Do they live in a food desert? Do they not have a working refrigerator at home to store the vials?
Can they not afford the exorbitant copay? Are they physically incapable of drawing up the dose due to severe arthritis?
A good residency teaches you how to conduct those investigative, empathetic conversations without judgment, and how to involve social workers and case managers to actually solve the root problem.
And that investigative mindset leads perfectly into domain number 2, quality and safety. This is entirely about training your brain in pattern recognition to catch latent errors before they ever reach the patient.
Quality and safety at this level relies heavily on understanding the Swiss cheese model of medical errors.
Which is so important.
Because when a catastrophic mistake happens in a hospital, it is almost never just one person's fault. It happens because multiple small, systemic failures, the holes in the cheese, lined up perfectly.
Maybe the pharmacy sent the wrong dose, the barcode scanner was broken so the nurse used a manual override, and the unit was short-staffed so the charge nurse couldn't double-check a high-risk drip.
Exactly. A residency trains your brain to constantly scan your environment for those systemic risks. It teaches you to critically question a physician's order that doesn't look right, rather than blindly following it just because an MD put it in the computer.
It builds the clinical courage required to speak up and stop the line.
And building that clinical courage is incredibly difficult. As a new grad, you are often terrified of paging a physician, especially in the middle of the night.
Oh, your heart is pounding out of your chest.
Yes. A good residency gives you the actual communication scripts, like the SBAR format, and the confidence to make that call without apologizing for advocating for your patient.
Now, that advocacy is heavily tied to domain number 3, informatics. This one is huge because we spend a massive portion of our shift staring at a computer screen.
But informatics is not about mindless clickbox charting just to satisfy the billing department.
No, informatics in a residency context is about learning how to wield the electronic health record as a clinical tool, not just a diary.
Right. It is looking at the potassium trends over the last 72 hours, reading the physical therapy notes to see how the patient tolerated ambulation, cross-referencing the intake and output flow sheets.
And synthesizing all of that disparate data into a cohesive story about what is happening physiologically to the patient. It is using technology to augment your clinical judgment, to catch the subtle changes in renal function or fluid volume status, rather than letting the computer replace your critical thinking.
Which naturally flows into domain number 4, evidence-based practice, or EBP. This is another massive buzzword in academia.
Right. Every paper you write in nursing school has to cite EBP.
But at the bedside at 3.0 a.m., EBP is simply about knowing the underlying why behind the tasks we perform.
It is the physiological logic. Why do hospital protocols dictate that we scrub the hub of a central line for a full 15 seconds before flushing it?
And it's not because the unit manager wants to micromanage your time.
No. It is because the microbiological evidence unequivocally shows that it takes a minimum of 15 seconds of aggressive mechanical friction to break down the biofilm of bacteria that colonizes on the plastic.
When you understand the scientific why, you are far less likely to cut corners when you are rushed. You don't follow protocols blindly out of obedience. You follow them because you understand the cellular mechanism that is actively protecting your patient from a central line-associated bloodstream infection.
And when you know the why, the task becomes non-negotiable.
Yeah.
It elevates your practice. And finally, we arrive at domain number 5, leadership.
Which can sound completely absurd to a new grad.
Oh, absolutely. You're thinking, I have been a nurse for 4 months. I am terrified of the IV pump. How on earth am I a leader?
Right. But leadership in this context is about developing your professional identity at the bedside.
It is about taking ownership of your practice and your patient's trajectory. You are the quarterback of that patient's care team for your 12-hour shift.
You are the central hub coordinating with pharmacy, dietary, respiratory therapy, physical therapy, and the medical team.
Leadership is learning how to effectively and respectfully delegate tasks to a nursing assistant. It is learning how to confidently present your patient in interdisciplinary rounds and firmly advocate for a change in their pain management strategy when the current regimen isn't working.
So we have thoroughly mapped out what a gold standard program looks like conceptually. A non-negotiable 12 to 18-month timeline, dedicated psychosocial check-ins to survive the 6-month dip, and a curriculum built on 5 robust domains that translate theory into bedside action.
Yes, that's the ideal.
But here is the gritty reality of the job market. Hospital recruitment teams are incredibly smart. They know that new grads are desperate for residencies, so they will use the term loosely to lure you in.
They absolutely will.
How does a nursing student sitting in an interview for their first job know if the hospital they're applying to actually has a legitimate supportive program, or if it's just a slick marketing brochure hiding a toxic unit?
We really need to talk about the green flags, the red flags, and the massive issue of the preceptor problem.
Yes, let's get into the practical advice.
This is the most practical advice we can give you. When you are sitting across from a nurse manager in an interview, you need to be actively looking for specific accreditation green flags.
Just like the nursing school you attended had to be accredited by a governing body.
Exactly. The absolute best nurse residency programs are nationally accredited by independent third-party organizations that rigorously verify their quality, their curriculum, and their outcomes.
I noticed in Brooke's notes that she highlights a few specific acronyms. What are the gold standard accreditations you should be listening for?
You want to explicitly ask if their program is accredited by the CCNE, which again is the Commission on Collegiate Nursing Education.
Okay, CCNE.
Another massive green flag is the ANCC PTEPI, which stands for the American Nurses Credentialing Center's Practice Transition Accreditation Program.
That's a mouthful, but PTEPI is the key there.
Right. You also want to look for hospitals utilizing the Versant model or the Vizient and ASEAN partnered programs. These aren't just fancy plaques on a wall.
They actually mean something.
To get these accreditations, a hospital has to submit to an intense audit. These third-party reviewers analyze the hospital's curriculum, they audit the training logs of the preceptors, they mandate specific retention data.
Wow, they even interview past residents to ensure the hospital is delivering on its promises, right?
They do. If a hospital holds one of these accreditations, you can be highly confident you are walking into a supportive environment.
Looking at the landscape of hospitals doing this right, a few incredible examples stand out. If we look at a model like Scripps Health out in California, their residency isn't just sticking new grads in a dark auditorium to watch PowerPoints.
Right, it's so much more than that.
They integrate intense one-on-one clinical coaching, highly structured peer support groups facilitated by psychologists, and formal mentorship programs that extend well beyond the first year.
That is incredible support.
Or you look at a mammoth institution like Massachusetts General, which has evolved to integrate highly specialized tracks into their residency. They have a geropalliative care track, recognizing that the aging demographic of their specific patient population requires new nurses to have advanced training in end-of-life care and complex chronic illness management right out of the gate.
Those are phenomenal urban examples, but we are also seeing incredible innovation in residency structures that span entirely different environments.
Yes, the Wisconsin Nurse Residency Program is a perfect example of this. I was looking into their model, and it is fascinating because it completely shatters the myth that you have to land a job at a massive 1,000-bed inner-city trauma center to get gold standard training.
It really does.
It's a massive cooperative model that integrates both large, high-acuity urban academic centers and tiny 15-bed rural critical access hospitals into the same residency framework. It provides rural nurses with the exact same high-level curriculum and peer support network as their urban counterparts.
The expansion of these programs into rural healthcare is revolutionary. And while we are evaluating the quality of these programs, we have to pivot to a major frustration that derails so many new nurses.
The red flags.
Yes. If a hospital does this, it is a glaring red flag. We need to talk about the problem of the rotating preceptor.
The rotating preceptor is a nightmare. It creates what I call the starting over syndrome.
Oh, that's exactly what it is.
Let's walk through how this actually feels at the bedside. On Monday, you are assigned to Preceptor A. Preceptor A has been a nurse for 20 years. They are super type A. They want the IV tubing labeled with the date in a very specific spot. They want you to perform and chart your head-to-toe assessment in a rigid, specific order.
And you just want to make them happy.
Right. You work incredibly hard for 12 hours to meet their exact standard. You feel good about it. Then you come back on Wednesday, and the charge nurse assigns you to Preceptor B.
And Preceptor B is a totally different person.
Totally different. Preceptor B is more laid back, tells you that Preceptor A is way too rigid, and demands that you organize your shift completely differently. You spend your entire 12-hour shift on Wednesday just trying to figure out what Preceptor B wants and how to avoid making them angry.
Which means you aren't actually learning clinical nursing.
Exactly. You are exhausting your cognitive energy, learning how to manage and please different personalities.
It is a massive drain on cognitive load. What we know from the neuroscience of learning under stress is that psychological safety is paramount. When you constantly switch preceptors, Preceptor B has no idea what you successfully accomplished on Monday.
They don't know your baseline.
Right. They don't know if you've successfully managed a PCA pump yet, or if you can independently insert a Foley catheter. And because they are legally responsible for the patient, they don't trust you.
So they make you start from scratch.
Exactly. They micromanage you to prove yourself all over again. It completely halts your clinical progression and shatters your confidence because you feel like you are perpetually trapped on day one of orientation.
A true gold standard program guarantees that you have a dedicated, specially trained preceptor, or, at most, a consistent pair of preceptors for day and night shifts who track your progression week by week.
They know your weaknesses,
Right.
They actively celebrate your growth, and most importantly, they know exactly when to step back and let you lead.
So, a rotating preceptor is a massive, blinking red flag. What are some other warning signs that a hospital's residency program is essentially fake?
Well, the most obvious red flag is the timeline. If a hospital recruiter proudly says, oh, we have a fantastic nurse residency program, it is 6 weeks long.
6 weeks.
Yeah, you need to understand that is absolutely not a residency. That is just standard bare minimum unit orientation that the marketing department has rebranded to sound appealing to new grads.
As we discussed in depth, the psychological and clinical transition requires a minimum of 12 months. 6 weeks barely gives you enough time to learn how to navigate the charting system, let alone develop complex clinical judgment.
Another critical red flag to watch out for is a lack of frontline nurse manager support.
How does that look in practice?
You see this frequently when a hospital has a residency program on paper, but the culture doesn't support it. You are scheduled to go to a vital 4-hour educational seminar on a Tuesday afternoon.
Oh.
But on Tuesday morning, your unit manager pulls you aside and says, hey, we had 2 call-outs today. We were really short-staffed. I need you to cancel your residency class and take a full patient assignment on the floor.
That is so unfair to the new grad.
It happens far too often in struggling hospitals. What that action explicitly tells you is that the organization values immediate short-term staffing numbers over your long-term professional development and safety.
A gold standard program hardwires the residency into the hospital's financial and scheduling matrix. The organization financially commits to paying you to be in that class, and unit managers are held strictly accountable by administration for ensuring you attend, regardless of staffing challenges.
You also need to look for how the program measures its own success. They shouldn't just be asking you, hey, how are you feeling, as you pass them in the hallway. There needs to be a formal evaluation process.
High-quality programs utilize validated, formal psychometric metrics to track your progress, right?
Yes. The most common and respected one is the Casey Fink Graduate Nurse Experience Survey. This isn't a casual check-in. They will formally survey you at the beginning of the program, at 3 months, at that critical 6-month dip, and at 12 months.
To objectively measure your confidence, stress levels, and clinical competence.
And crucially, they actually use that data in real time to adjust a program to what your specific cohort needs. If the survey shows that 80% of the cohort is terrified of calling physicians, the residency coordinators will immediately schedule a seminar on interdisciplinary communication.
That's amazing. If a hospital has no formal, data-driven way to evaluate how their residents are actually doing, they aren't truly invested in the outcome.
Exactly.
We have spent a lot of time dissecting the structure, the timelines, the green flags, and the red flags. Let's transition and connect all of this directly back to the reality of bedside nursing.
Let's do it.
Let's talk about the real bedside impact and the ripple effect of these programs. Why does a hospital spending millions of dollars and thousands of hours on a massive residency program actually matter to the patient lying in the bed in front of you and to your own long-term career trajectory?
It all comes down to the concept of retention. But we need to fundamentally reframe how we think about retention. Retention is not just a human resources metric about hiring costs. Retention is a critical patient safety issue.
Say that again, because that is huge.
Retention is a critical patient safety issue. The clinical data is incredibly stark on this point. The turnover rate for new graduate nurses who are thrown into the fire without structured residency support is staggeringly high, sometimes reaching 30 to 40% in the first year.
That's almost half of new nurses leaving.
Right. But when you look at nationally accredited 12 to 18-month residency programs, the retention rate jumps to nearly 87% to 95%. That drastically reduces the constant churn and turnover that plagues so many nursing units.
Let's apply some real bedside logic to those numbers. Let's visualize what retention actually looks like on a shift. When turnover is low, a unit retains its experienced veteran nurses.
Yes, the seasoned nurses stay.
If you are a new grad working on a stable unit and your patient's blood pressure suddenly drops to 70/40, you are going to feel a wave of sheer panic wash over you. It is inevitable.
Oh, your stomach drops.
But on a stable unit, you can step out into the hallway, look next door, and see a seasoned 15-year veteran nurse charting. You can say, hey, I need help. Can you come look at my patient? And that veteran will be in the room in 3 seconds.
They'll help you throw the bed in Trendelenburg. They'll help you run the fluid bolus wide open.
They will help you call the rapid response team, and they will help you stabilize the patient. You are never truly alone.
Now, contrast that exact same clinical emergency on a unit that suffers from high turnover because they don't support their new grads. If a hospital burns out its nurses, the experienced ones leave for better environments.
Which leaves only the new grads.
For a new grad, that means the terrifying reality is you might be the most senior, experienced nurse on the night shift after only a year and a half of practice. High turnover means a unit is constantly staffed entirely by beginners.
So when that patient's blood pressure drops to 70/40 and you look out into the hallway for help,
everyone else is just as new, just as panicked, and just as overwhelmed as you are. There is no safety net that directly, measurably compromises patient safety.
An investment in a residency program is an investment in building a stable, deeply experienced team that has the collective wisdom to catch the subtle physiological changes before patient codes.
It really is a profound ripple effect. Supporting and nurturing one new nurse makes the whole unit safer for every single patient admitted to that floor.
I also want to touch back on where to look for these jobs because there is a heavy bias in nursing school. Finding a job in a massive urban academic center can sometimes be highly competitive or just generally overwhelming for a new grad who doesn't want to live in a sprawling metropolis.
That bias is very real. There is a pervasive misconception that you have to go to a massive 800-bed inner-city trauma center to get good clinical experience or to find a high-quality residency.
But as we discussed with the Wisconsin cooperative models, we are seeing excellent residency programs expand rapidly into rural hospitals.
Rural nursing is such an incredible deeply challenging and often overlooked starting point for a career.
It absolutely is, and it requires a unique breed of clinical courage. In a massive urban hospital, you have immense resources at your fingertips. You have a specialized IV team to start difficult lines. You have a dedicated code team that responds in seconds.
You have a respiratory therapist assigned to every single floor, and you have a resident physician sleeping in a call room just down the hall.
But in a rural critical access hospital, you don't have any of that.
No, you are the IV team. You are the respiratory therapist managing the vent until help arrives. You are running the entire code blue until the single ER doctor in the building can physically run upstairs to relieve you. You wear every single hat.
The autonomy is staggering.
It is. And that is exactly why rural residency programs are so vital. They offer incredible professional development and a tight-knit, deeply invested social support network.
For a new grad, a rural environment paired with a strong residency program is an amazing place to build highly robust, generalized clinical judgment. You see everything from pediatric emergencies to agricultural trauma to acute myocardial infarctions, and you learn how to manage and stabilize all of them with limited resources.
It is the ultimate trial by fire, but the residency provides the fireproof suit. And that evolution, whether it happens in a 15-bed rural facility or an 800-bed urban center, is really the ultimate shift we are talking about today.
The entire goal of this conversation, understanding the 12 to 18-month timeline, mastering the CCNE domains, demanding dedicated preceptors, is to facilitate your transition from feeling like an imposter who is just frantically checking off tasks on a to-do list to becoming a confident, autonomous clinician.
It is the cognitive shift from simply knowing what task to perform to deeply understanding why you are performing it.
It's the ability to effectively communicate a critical change in a patient's condition to the interdisciplinary team using objective, evidence-based language rather than just calling a doctor and vaguely saying, well, my patient doesn't look right.
Exactly. It is stepping fully and confidently into the role of the patient's ultimate advocate.
Let's bring this all together with a quick recap of the most important lessons from our conversation today. Nurse residencies are not just extended orientations to hospital geography.
No, they are comprehensive, 12 to 18 months lifelines designed specifically to build your clinical judgment, facilitate your professional socialization, and protect your mental health through the 6-month confidence dip.
When you are applying for jobs, you need to actively look for accredited programs, demand a minimum length of 12 months, and insist on dedicated, consistent preceptors to avoid the starting over syndrome.
The most practical takeaway we can leave you with is this. When you are sitting in an interview for your first nursing job, you need to interview the hospital right back.
Yes, the power dynamic has shifted. They need you just as much as you need them.
Do not just sit there passively hoping they pick you. Ask the nurse manager directly. Is your residency program nationally accredited? Ask them, how long does the formal structured support last after my unit orientation ends?
And explicitly ask them, will I have a dedicated preceptor, or will I be rotating among staff?
Use those specific questions to protect your license and ensure you land in an environment that is genuinely going to nurture your growth, rather than a facility that just wants to use your newly printed license to plug a dangerous staffing hole.
Becoming an amazing expert nurse doesn't happen overnight. It takes time. It takes a tremendous amount of grace for yourself. And it takes a structured, supportive community holding you up while you learn.
I completely agree.
And before we go, I want to leave you with a fascinating thought to mull over, something that builds on everything we've talked about today regarding the future of how we train new nurses. We talked a lot about the anxiety of phase 1 orientation, learning your skills on real patients who are incredibly sick.
A lot of pressure.
But the landscape of nurse residencies is on the verge of a massive technological disruption. Over the next 5 to 10 years, we are going to see artificial intelligence and hyper-realistic virtual reality completely revolutionize phase 1 training.
Oh.
Imagine, instead of practicing a code blue on a plastic mannequin, you put on a VR headset and are immersed in a chaotic, AI-driven hospital room where the virtual patient's physiology reacts in real time to the medications you push.
That would be wild.
You can make the catastrophic mistake of giving the wrong dose of epinephrine, see the virtual patient code, and learn the lesson viscerally without ever harming a real human being.
The integration of AI simulations could entirely remove the fear of harming from the first 3 months of practice.
Exactly. Allowing new nurses to build confidence in a zero-risk environment before they ever touch a real patient. It is going to fundamentally change the reality shock we've discussed today.
It is a profound shift in clinical education, and it'll be fascinating to see how hospitals integrate that technology into their residency accreditations.
It really will be. Thank you all so much for spending your time with us today on this episode of the Super Nurse Podcast. We invite you to go watch the comic book style video of this exact conversation on YouTube at Super Nurse Comics.
Please like, subscribe, and leave a comment telling us about your own orientation experiences, the good, the bad, and the ugly.
And please visit supernurse.ai for incredible resources designed specifically to help you become the super nurse you were born to be.
Remember that terrifying moment we talked about at the very beginning, when the training wheels come off and the IV pump is blaring? If you choose the right residency program, that won't be a moment of pure, unadulterated overwhelm.
No, it will be the exact moment you realize you have the critical knowledge to handle the emergency and an entire experienced team right behind you ready to help. Keep learning, keep asking the hard questions, and we will see you next time.